Hi, this is Brian Kim. I want to share with you this case of a patient with a very tiny and fibrotic pupil. This patient also is mentally disabled, and so I had to figure out the most efficient way to open up the pupil and perform cataract surgery. And so I decided to place a Malyugin ring, and you'll see how I use a Malyugin ring. I don't use it very often, but when I do, I try to do it as efficiently as possible. And so this is my technique on how I put the Malyugin ring. You'll see trypan blue placed as well, and try to do my best to efficiently disassemble this lens and try to get out as quickly as possible, because this patient is somewhat of an unreliable patient with unpredictable movements. So you can see this is a patient's dilated pupil, but it's clearly quite small and didn't really dilate very much. You can see on the left side there's a little bit of a fibrotic membrane as well. I'm using the corneal mark to help me center inside my rexus, make my paracentesis incisions, first on the right side and then the left side, making sure the incision is flat to the iris plane, which will create a nice shelf to allow me to achieve a self-sealing incision. This is intracameral lidocaine and then now intracameral epinephrine. Basically, nothing really happens. So I'm injecting some intracameral viscoelastic, but you see here, I'm not injecting it too much because I plan to paint the anterior capsule surface afterwards. So I inject just a little bit, just to fill the chamber. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. And now this is a Malyugin ring. I'm lifting the incision with the Lester hook, placing the Lester in the paracentesis incision, going ahead and delivering the leading eyelet. This is a two-handed technique, making sure the eyelet grasps the edge of the pupil, and then you want to make sure you do the same thing with the side eyelets. And all it takes is just directing the eyelet so that it catches the pupil edge. And so the trailing one is the key. You want to make sure the device has been completely disengaged from the ring, and then you use a Lester to hook the last eyelet. And so that's the way I like to do the technique, a two-handed technique with the injector, and it's just really pretty efficient that way. So I'm injecting some intracameral air, and then now some intracameral trypan blue to paint the anterior capsule surface. And as you saw in the beginning, I didn't put a whole lot of viscoelastic, so it didn't really compress and touch the anterior capsule surface. And by doing it this way, I was able to really get a much better staining of the anterior capsule. But of course, even if you filled it with viscoelastic, you can still paint it with a paint roller effect on the anterior capsule surface. This is some dispersive viscoelastic to fill the anterior chamber and to push out the air bubble and coat the corneal endothelium. I suspect this patient's going to have a fairly floppy zonule situation. And as I start to cut with the cystotome, you can tell it's a little bit loose. Now I stop here, but then I decide to go back because I want to make the rexus just a little bit bigger, and it's because the ring is not quite centered. So I'm using the cystotome to gently pull on the ring to try to center it a little bit more. And so this allows me to make sure I extend this rexus just a tad bit to get a nice rexus that corresponds with my corneal mark. So I switch to the forceps and I go around circumferentially. And of course, the ring does a great job in dilating the pupil. It's a very stable situation. The trypan blue really helps me visualize the capsule very nicely here. Thankfully, it's not an intumescent lens, but you can tell it wants to go out just a little bit. You just have to pull centrally just a little bit to make sure it doesn't go out. This is the capsular fornix hydrodissection technique. I place the cannula out underneath the rexus edge contra-incisionally. Get into the capsular fornix, point the tip down, get a nice wave. Of course, the lens is so dense you can't really see the wave. So I lift it up, and then I just kind of decompress on the left side. And as I do this, I can tell that the lens begins to spin quite easily in this case. In cases where you can't visualize the wave, it's very important not to be so aggressive with the hydrodissection. You can blow out the posterior capsule. Irrigate the surface of the cornea, go in with irrigation off to minimize Descemet's trauma. Remove the surface epinuclear material. Place the chopper under the rexus edge contra-incisionally. Point the phaco tip vertically sub-incisionally, bringing both instruments together, and it actually fractures the lens pretty effectively in this case. Place the chopper around the right heminucleus, pulling it centrally toward the phaco tip, and I'm able to fracture the right heminucleus here as well. Using a little bit of vacuum, lifting that first quadrant up, and then crushing it between the instruments, and then emulsifying the lens pieces. In these cases, there's typically not much epinucleus or cortex, and so you want to be very mindful that the posterior capsule may be exposed in these cases. Go ahead and turn the lens to get the second quadrant in front of me, placing the chopper around the quadrant, pulling it centrally toward the phaco tip, fracturing the lens piece, emulsifying the small lens pieces, using some vacuum to grab that fragment, crushing it between the instruments, and then emulsifying the lens pieces. As you can see, there's very little protection from the posterior capsule and with this dense lens. I'm just going to be mindful, make sure I don't point that phaco tip deep in the bag with vacuum on at any point. So I turned the second heminucleus in front of me to place the chopper around the lens piece, pulling it centrally towards the phaco tip, crushing and dividing the lens. You can see there's some deep adhesions there as I try to separate. Place the chopper around that third quadrant, crushing it and dividing it in half, and then crushing it into smaller pieces, and then emulsifying the lens pieces. I'm trying to use that vacuum to position that piece on the tip, and then I sandwich it with the instruments and then emulsify the lens piece. It's much easier to just turn the chopper around and hooking the lens piece and then crushing it that way. And so that's kind of the maneuver that I prefer to do. Position the lens piece between the instruments, primarily using the chopper to hook around the lens piece and then sandwiching the lens piece. That's really the benefit of having that longer chopper. Once most of the fragments have been emulsified, you want to be very mindful of any post-occlusion surge. You don't want to use real heavy pedal to metal phaco or pedal to the metal vacuum in this situation. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. There's some nuclear fragments on the tip, so I use the cannula to mash it into the tip. I'm adjusting my sleeve. I start sub-incisionally removing the cortex. You can see there's some big chunks that are coming out, and then there's a pretty dense chunk that's on the tip there. Rather than switching to the phaco tip, I'm just going to use a cannula to mash the pieces into the INA tip. It's not that efficient, but with high vacuum, you'll be able to slowly remove those small pieces. Okay, those pieces are finally removed. And I start sub-incisionally removing the cortical material from anterior to posterior. You can see how thick this epinuclear material is. It's very, very thick. I'm using the cannula again to mash it. Again, not very efficient because it does take some time. However, probably safer than going with the phaco tip in that situation. So far, this patient hasn't really misbehaved, and so I'm cautiously optimistic and moving forward as efficiently as I can, but not skipping any steps in the process. Even though this patient is disabled, I don't want to skip any steps and not do the things I should do. I try to do my very best for every single patient, and so trying to find that balance between moving efficiently but also being thorough. So with these dense lenses, the zonules can be weak, and so I'm polishing under the rhexis edge, under the iris, under the polish mode. Go and place a BSS cannula and pulse it into the subincisional space, and there's not much there that I can see. Again, I'm being cautious because I don't want the patient to suddenly move. So go ahead and inject some cohesive viscoelastic to fill the bag. There's a little bit of cortical remnant in the subincisional space there. We try to go after that. And I'm able to liberate that material with the sweep. So continue to sweep on the left side. And then sweeping on the right side. This is a 3-piece lens. Any dense lens with potential weak zonules, I like to put a 3-piece lens. So I have to widen the incision with my diamond blade. And sometimes when I have to push the injector in, it can cause viscoelastic to come out. So I switch to the cohesive viscoelastic cannula so that when I push it in, I can push some more viscoelastic very quickly. So it just skips a step by doing it that way. Delivering the leading haptic pointed to the left with the bevel pointed to the left. As the optic is delivered, I rotate the barrel counterclockwise so the optic comes out in the correct position. And I rotate it even some more to make sure that the trailing haptic comes out of the eye, pointed towards the right. And this is a Maltzman. I'm going to go ahead and dial it into the bag. I have a nice, well-centered lens, good capsule overlap, 360 degrees. So this is using the Lester through the paracentesis. I'm going to try to disengage that subincisional eyelet first. As I do that, I place the shooter for the ring in, and then engaging the eyelet, letting it collapse into the barrel of the injector, making sure the iris is completely disengaged. Some people just pull it right out, but if you do that, it's going to traumatize the iris root and potentially cause a hyphema. So in this case, I use the Lester to help gently disengage the eyelet of the Malyugin ring from the pupillary edge. So I go in with the INA, activate irrigation, and then go under the lens, removing the viscoelastic from within the bag. You can see there's a big chunk there still. Removing the viscoelastic from within the bag and then within the anterior chamber. You're going to be able to appreciate how floppy this iris is once I get all the viscoelastic out from the anterior chamber. And then I'll hydrate my incision. So again, this is a patient who's mentally disabled, tiny fibrotic pupil, dense cataract. And so you saw my efficient two-handed Malyugin ring placement as well as removal. Again, this is a very efficient and controlled way. I have been able to minimize any potential complications doing it this way because that eyelet can hold that iris. You have to be very careful. And a two-handed technique is really the best way to in a very controlled manner disengage the eyelet from the pupil edge. And then you saw double chop, cross chop, mechanical fracturing techniques to really try to utilize as little amount of ultrasonic energy as possible. This patient ended up doing very well, even though he's nonverbal. He was able to improve his function. He's able to get around in his house a lot better as a result of the surgery. And so I feel like double chop, cross chop, mechanical fracturings, efficient Malyugin ring placement. In this case, I think hooks would be a bad idea because this patient could move suddenly in the middle of the case. I want it to be in and out as quickly as possible, but also not to cut any corners. And so I feel like this is really a very efficient way to disassemble the lens, a thorough way to disassemble the lens, as well as a very efficient way to place the Malyugin ring and remove the Malyugin ring. So I hope this was helpful to you, and I thank you for your attention.